All right, if you're a GP in the Netherlands, you're going to want to pay close attention. In this explainer, we are breaking down the February 2023 update to the Dutch GP guideline for liver diseases. That's the NHG-Standaard M22. And trust me, this isn't just a minor refresh. It's a pretty big shift in how we're expected to screen, refer, and manage liver conditions. So let's get right into what you actually need to change in your day-to-day practice.
Here's the game plan. We're going to cover 5 key things. First, the big headline changes in the new standard. Then, we'll talk about the new non-negotiable mandate for hepatitis B and C. Third, how to get better at spotting patients who are at risk. Fourth, we'll look beyond viruses to things like fatty liver disease. And finally, we'll wrap it all up with your new actionable playbook.
Okay, so let's be clear, the MC22 guideline is not just a little tweak here and there. It represents a major shift in our whole approach to liver disease. And we're going to start with the single most fundamental change, and it's all about chronic hepatitis B.
Now this right here is a real game changer. For years, we used to split chronic hepatitis B into 2 camps, active and inactive. Well, you can forget that. That distinction, it's gone. The new standard is crystal clear. If a patient has chronic hepatitis B, they need lifelong monitoring. Full stop. And this is a huge deal because it means all those patients we once labeled as inactive carriers now need to be brought back into active follow-up.
And building right on that, there are a few other massive updates. As a GP, your role is now laser-focused on just 2 things: identification and referral for all chronic Hep B and C cases. All the treatment is now happening in specialized centers. And it's not just about viruses anymore. The guideline has been beefed up with much clearer advice on managing non-alcoholic fatty liver disease, or NAFLD, and also drug-induced liver damage.
So, that leads us right into the new mandate for hepatitis B and C. The guideline basically redefines our primary job, and it boils it down to a super clear directive. Your job is to find them, and then you refer them.
And you don't have to take my word for it. This quote from the guideline's core message says everything. Refer all patients with chronic hepatitis B to a hepatitis treatment center. This is not a suggestion, it's a directive. And the exact same thing goes for hepatitis C. You know, with how complex and effective modern treatments have become, the days of trying to manage these cases all by ourselves in primary care, well, they're over.
So what does this actually look like in your clinic? It's a really simple 3-step pathway. Step 1. Your patient tests positive for the hepatitis B surface antigen or for hepatitis C antibodies. Step 2. You confirm it's a chronic case. You either show the Hep B antigen has been there for more than 6 months, or you get a positive HCV RNA test. And Step 3. You refer. That's it. No exceptions. Every single confirmed chronic case has to go to a specialized treatment center.
So why all this new urgency? Well, it's because we are dealing with a silent epidemic. There are a huge number of people in the Netherlands living with undiagnosed chronic viral hepatitis. And you know what? Your practice is the absolute front line for finding them.
Just get a load of this number. An estimated 40,000 people have chronic hepatitis B, and a lot of them got it when they were young, especially first-generation migrants from countries where the virus is really common. And the tricky part? They are often totally asymptomatic.
And it is a very similar story for hepatitis C. We're talking about an estimated 28,100 people living with a chronic infection. I mean, these are not small numbers. These are people sitting in our waiting rooms every single day.
So who should we be keeping an eye out for? This slide really breaks it down for us. For both Hep B and C, we're definitely looking at first-generation migrants from endemic areas, men who have sex with men, and anyone with a history of IV drug use. Then, for hepatitis B specifically, you also want to add anyone with many changing sexual partners to that list.
But the guideline gets even more proactive than that. It explicitly says we should think about offering a one-time screening test for Hep B and C to any patient who walks into our clinic if they're from a country where these viruses are common. We don't have to wait for symptoms or some special reason. The consultation itself is the opportunity. Okay, so we've talked a lot about viral hepatitis, but that's not the whole story. The updated guideline also really broadens its scope to help us manage other common liver issues, especially non-alcoholic fatty liver disease. So what is NAFLD? Well, it's pretty simple, really. It's just fat building up in the liver that isn't from alcohol or other specific causes. And it is incredibly common. It's the kind of thing that just pops up as a surprise finding on an ultrasound or because of slightly elevated liver enzymes. And this is why we need to care about it. NAFLD isn't just about the liver. It's tightly linked to metabolic syndrome, so type 2 diabetes, obesity, high cholesterol. But here's the crucial takeaway from the guideline. Patients with NAFLD have double the risk of cardiovascular disease and a 1.5 times higher risk of overall mortality. This basically reframes NAFLD as a systemic risk factor that we now need to manage proactively.
And just as a final point here, it's worth mentioning that the standard now gives us much more detailed advice for drug-induced liver damage. It offers clear guidance on when to monitor, when you need to stop a medication, and when to refer, which is super helpful for navigating those tricky clinical situations.
So, we have covered a lot of ground. Let's boil all of this down into a new GP playbook, a simple, actionable summary that you can take back to your practice literally today. Here are your 5 core actions. Number 1, be proactive. Screen your high-risk patients and anyone from an endemic country for Hep B and C. 2, don't hesitate. Refer every single patient with confirmed chronic hepatitis B or C to a treatment center. 3, keep an eye on those liver enzymes. If the ALT is repeatedly more than 1.5 times the upper limit, dig deeper. 4, know the red flag. If the ALT ever goes above 10 times the upper limit, that's an immediate referral. And 5, change how you think about fatty liver. Manage NAFLD first and foremost as a cardiovascular risk factor.
And that really brings us to our final thought. The new M22 standard gives us a much clearer, more powerful role in managing liver disease. But the real challenge isn't just knowing this stuff, it's doing it. Knowing that there are an estimated 40,000 people out there with chronic hepatitis B, the question for all of us is, how are we going to use this new playbook to find them, refer them, and finally close that critical gap in care?